So good evening, everybody. Last session. Everybody ready? Excited? All right. Okay, so I have no disclosures relevant to this presentation. So let's jump right in. Question 1. So the administration of amiloride may be beneficial for which of the following situations? A genetic defect for the thick ascending limb luminal potassium channel ROMK, a defect for the epithelial sodium channel, an inactivating mutation, a defect for the 11-beta hydroxysteroid dehydrogenase enzyme, defect from the fusion of portions of the 11-beta hydroxylase gene and the aldosterone synthase gene, or a defect for the epithelial sodium channel, an activating mutation. So I'm going to keep the time to about 20 seconds per question just to get through it all. Okay. All right, so let's see. So the majority of people chose E, an activating mutation, which is the correct answer. So this is genetic defect for the epithelial sodium channel, activating mutation. So if one thinks about the epithelial sodium channel in terms of the principal cell function in the distal tubule, here we see the urine or the luminal surface of the membrane. We have the epithelial sodium channel here, which is amiloride sensitive. A gradient for the inward direction of sodium is created by the basolateral NAK ATPase, which pumps 3Na out for each 2K plus in, creating this negative gradient allowing sodium to transverse through the ENaC channel. The increase in negative charge as you lose positive ions from the sodium intrusion into these cells creates a relatively negative lumen, which allows the secretion of potassium through ROMK and also facilitates H plus secretion. Okay, and again, this negative lumen actually helps to facilitate the paracellular transport of chloride through the paracellular route. So this is in essence Little syndrome, which is an activating mutation of the epithelial sodium channel in the collecting duct. It's inherited as an autosomal dominant trait. It has an early onset of hypertension and characterized by hypokalemia and metabolic alkalosis. So question 2, a follow-on. Which of the following set of laboratory findings is consistent with Little syndrome? Low renin, low aldosterone, high potassium. Low renin, high aldo, low potassium. High renin, low aldo, high potassium. High renin, high aldo, low potassium. Or low renin, low aldo, low potassium. Take your pick. Okay, so I'm going to stop it there. Let's see what we got. So a bit more of a splay here, but most people going for E. And so the correct answer is E. This is the low renin, low aldo, low K state. And again, if you think about the pathophysiology, an activating mutation creates the sodium influx into the cells, creates a negative lumen. And so you lose K plus, or at least K plus is facilitated in terms of the ROMK channel, which leads to hypokalemia. The reabsorption of the sodium creates like a sodium avid state essentially, and so the high sodium will suppress renin and in turn suppress aldosterone. So it's a low renin, low aldo, low potassium state. When one thinks about hypertensive renal potassium wasting, it can be categorized into 2 major categories, high renin and low renin states. The high renin differential includes renovascular disease, malignant hypertension, rarely, but sometimes board questions, renin secreting tumors, and some forms of Cushing's disease. The low renin states really think about Conn syndrome, bilateral adrenal hyperplasia, glucocorticoid remediable hyperaldosteronism, the apparent mineralocorticoid excess syndrome, certain types of licorice ingestion, and Little syndrome. So question 3, a 61-year-old man with end-stage kidney disease secondary to type 2 diabetes mellitus experiences large interdialytic weight gains and recurrent episodes of intradialytic hypotension in his outpatient unit. Strategies proven to mitigate against interdialytic hypotension include all of the following except lowering of the dialysate temperature below the body temperature, use of dialysate sodium modeling, use of lower dialysate calcium concentrations, or the administration of hypertonic mannitol. Okay, so we'll stop there. And so bit of a splay here. So 19 or 40% of people choosing C and 45% choosing D. So the correct answer here is actually C. So lower dialysate concentration is incorrect. So interdialytic hypotension has numerous definitions. The one used by the Kedogi guidelines is a decline in systolic blood pressure of 20 millimeters of mercury accompanied by patient symptoms. But like I said, there are as many definitions as one can think of here. In general, it's estimated to complicate up to approximately 1/3 of outpatient dialysis treatment sessions. And various strategies have been proven to reduce the frequency and magnitude of interdialytic hypotension, including the use of sodium modeling, cooled dialysate, isolated ultrafiltration, hypertonic fluid administration, including mannitol, even vasopressin infusions, and higher dialysate calcium as opposed to lower, which is why lower is incorrect. So question 4, which of the following statements regarding cooled dialysate is true? Cooling the dialysate increases stroke volume. Cooling the dialysate increases systemic vascular resistance. Cooling is associated with decreased circulating norepinephrine concentrations. Cooling is associated with reduced dialysis adequacy. Or cooling is associated with post-dialysis hyperkalemia. So which of those statements is true? Okay, stop here. So the majority of people are choosing B, okay, which is the correct answer. So cooling increases systemic vascular resistance. So cooled dialysate has been shown to increase SVR, thereby promoting blood pressure stability during hemodialysis. Despite concerns of centralization of blood flow with this strategy, previous studies have not shown any significant decrease in dialysis adequacy. Numerous small studies on outpatients have noted a reduced frequency of myocardial wall motion abnormalities and a reduced frequency of cerebral white matter changes over time with cool dialysate use. The major patient symptoms to be aware of with this strategy include shivering, which can actually be quite severe in some cases. So question 5. A 45-year-old man has been vomiting for 2 days and has orthostatic hypotension and a serum potassium of 2.9 milliequivalents per liter. The blood pH is 7.54. The urine pH is 6.8. Which of the following statements is false? The urine sodium concentration is greater than 25 milliequivalents per liter. The urine potassium concentration is greater than 15 milliequivalents per liter. The urinary anion gap is positive. The hypokalemia is mostly due to gastric losses. Or the serum bicarbonate is greater than 30 milliequivalents per liter. Which of those statements is false? Okay, so I'll stop it here. So big splay here. Okay, so the correct answer here is D. D is false. The hypokalemia is mostly due to gastric losses. That is an incorrect statement. So let's talk about vomiting and the serum potassium. The potassium concentration in gastric fluid is relatively low. It's only around 5 to 10 milliequivalents per liter. So losing a lot of gastric contents in vomitus will not cause hypokalemia. However, the loss of large amounts of hydrochloric acid in gastric secretions leads to a metabolic alkalosis and subsequent hyperbicarbonatemia and resulting bicarbonaturia will result in volume depletion with activation of the renin-angiotensin-aldosterone system, and this will lead to secondary hyperaldosteronism. The secondary hyperaldo state promotes potassium secretion via increased activity of the H plus K plus ATPase and increased activity of ENaC. The bicarbonaturia draws sodium ions in order to maintain urine electron neutrality, and so in these states in volume depletion with metabolic alkalosis, the urine sodium may be higher than expected than one would typically see with a volume contracted state. In these settings, the urine sodium is not a good surrogate for intravascular volume status. The urine chloride is more helpful in this regard. So if one thinks about hypokalemia and the assessment for renal potassium loss, You can either find an increased or decreased renal potassium loss. If you measure renal potassium concentrations and it appears to be decreased, you may think of transcellular shifts or extra renal losses, predominantly from the GI tract. If you do find increased renal K loss, then you should go down this pathway. Assessment of the blood pressure, the effective arterial blood volume. If you find this to be high, you might check a PRA and an aldosterone. And then you're into the whole differential of high renin, high aldo states, low renin, low aldo states. So high renin, high aldo associated with renal artery stenosis, reninomas. Low renin, high aldo with predominantly with adrenal abnormalities such as adenomas, bilateral hyperplasia, glucocorticoid-remediable aldosteronism. And low renin, low aldo, Cushing's, CM, Little syndrome, 11 beta and 17 alpha hydroxylase deficiencies. If you assess the blood pressure, effective arterial blood volume, you find this to be low, next thing to check is the serum bicarbonate. If the serum bicarbonate is low, you might think of proximal or distal renal tubular acidoses. If the serum bicarbonate is high, you might check the urine chloride next. The urine chloride is typically low in vomiting, with certain non-reabsorbable anions such as some penicillins, such as ticarcillin, and the urine chloride will be high in the setting of diuretic use, magnesium deficiencies, and our old favourites, Barter's and Gittleman syndrome. In terms of evaluating for urine potassium wasting, obviously a detailed history is of extreme importance. 24-hour urine collections would be the next step, but are probably the most accurate. Urine K conservation can lower renal losses as low as 25 to 30 milliequivalents per day. So there's a phenomenal capacity to retain potassium in the setting of hypokalemia from the kidneys if the kidneys are working well. Obviously, the 24-hour collections are quite cumbersome, so spot samples can be used. Again, the minimum K concentration achievable is around 5 to 15 milliequivalents per litre. They should be interpreted in association with the urinary volume. An alternative here is the urine potassium to creatinine ratio, with values less than 13 milliequivalents per gram, suggestive of non-renal losses. The transtubular potassium gradient has really fallen out of favour, but when used, there are certain caveats in terms of its interpretation, such as the urine sodium should be at least 25, so that the potassium, the distal potassium secretion, is not limited by distal sodium delivery, and the urine osm should be greater than the plasma osm. But again, the TTKG has really fallen out of favour in most electrolyte experts. So question 6, a 33-year-old male with a known history of alcoholism and substance abuse is admitted to the emergency room. He has been drinking heavily for the last week and admits to several episodes of vomiting for the last 3 days. He is hypoglycemic on admission and is treated with normal saline, thiamine, and glucose. 4 hours later, he develops a generalized tonic-clonic seizure. What is the most likely cause of this event? Is this hypernatremia from the saline infusion, lowering of the ionized calcium as his metabolic alkalosis corrects, hyperglycemia from administered glucose solutions, hyperkalemia from correction of a metabolic alkalosis, or hypophosphatemia from stimulation of insulin release? So I'll stop it here. So a bit of a variety here as well. Some people choosing B, A, and E. The correct answer here is actually E. This is hypophosphatemia from stimulation of insulin release. This is the very characteristic narrative of refeeding syndrome. So the patient likely develops severe hypophosphatemia as a result of insulin release in response to the administered glucose. The underlying acid base was most likely a metabolic alkalosis from vomiting, with a concomitant low or low normal potassium from the secondary hyperaldosteronism that we just explained a few slides ago. Restoration of volume status with normal sealing may exacerbate his low potassium, in addition to the effects of insulin release, which again can further drive potassium into cells. Correction of an alkalosis will increase ionized calcium levels rather than decrease, and he is unlikely to develop hypernatremia from a normal saline infusion. The refeeding syndrome is characterized by several electrolyte abnormalities, including hypophosphatemia, hypokalemia, hypomagnesemia, and other vitamin and trace mineral deficiencies, and also with volume overload and edema. Total body phosphate depletion is exacerbated by the administration of carbohydrate, which leads to insulin release, further driving phosphorus into cells. This drives the intracellular uptake of phosphate and stimulation of ATP and 2,3-DPG production. Severe hypophosphatemia can lead to several muscle abnormalities, including myocardial, skeletal, and diaphragmatic reduced contractility, rhabdomyolysis in severe cases, as well as bradycardia, abnormal liver function tests, and seizures. Caloric intake in this setting should be increased gradually, and all electrolyte abnormalities corrected before the institution of the refeeding process. Okay, so question 7. Which of the following statements regarding the use of vasopressin receptor antagonists is false? The antidiuretic response of vasopressin receptor antagonists is mediated primarily via the V2 receptors. Upon initiation of vasopressin antagonists, strict free water intake restrictions must be maintained. Conivaptan must be administered intravenously. Tolvaptan use should be avoided in patients with liver failure. Conivaptan blocks both V2 and V1A receptors. So which of those statements is false? Okay, so let's have a look. So most people are choosing B as the false one, which is correct. Okay, so a quick jump through the different types of vasopressin receptors. So the V1A receptors are present in endothelial cells and upon activation cause vasoconstriction. V1B responsible for ACTH release, and the V2 receptors are located predominantly in the kidney and are responsible for antidiuresis. So V2 receptor antagonists or Vaptans should not be used in hypovolemic patients. Recent concerns have limited tolvaptan use to a maximum of 30 days and advised avoidance in patients with liver disease. And upon initiation, you should relax free water restrictions when using Vaptans. Here's just a schematic of how it works. So you've got the basolateral membrane here in the distal tubule, the V2 receptor, arginine vasopressin coming to bind to this, and via this G-linked protein with adenyl cyclase causes this intercellular series of reactions that translocates the aquaporins into the apical membrane. Note also that there's a potential inhibition of this pathway by prostaglandins, and so non-steroidals are an obvious thing to watch out for in these types of questions as well. So question 8, a 52-year-old Caucasian female is referred for evaluation of dipstick albuminuria. Her medical history is notable for long-standing pain in her hands and feet, which is worse with exercise in hot weather. She denies smoking and alcohol intake or illicit drug use and takes no regular medications and has no allergies. Her blood pressure is 108 on 68, heart rate of 72, the pulse is regular and she appears euvolemic. Inspection of the skin reveals several 1 to 2 millimeter reddish purple macules around her umbilicus and lower abdomen, which she claims are unchanged and there as long as she can remember. Her analysis reveals a spectra of 1010, negative heme, and 2+ albumin. Which of the following is the next most appropriate diagnostic test to perform? Measurement of alpha-galactosidase A activity in peripheral blood leukocytes, plasma anti-PLA2R antibodies, a kidney biopsy, bidirectional sequence analysis of the GLA gene, or a fasting plasma glucose? Which is the next most appropriate diagnostic test? So I'll stop it here. So a lot of people going for A and a bit of a spread otherwise. So let's see. So the correct answer here actually is D, okay? So the next most appropriate step in a female with this presentation is actually to do a genetic sequence analysis. So this presentation should raise the concern for Fabry's disease, which is an X-linked multisystem disorder characterized by mutations in the GLA gene coding for the alpha-galactosidase enzyme, which leads to accumulation of globotriacylceramide in cells. Presentation is very characteristic: acroparesthesia, autonomic neuropathies, early onset strokes, left ventricular hypertrophy, proteinuria, chronic kidney disease. And again, it can extend to other systems, including GI and skin with angiokeratoma, corneal whorls, and impaired sweating. Because it's X-linked, females can have varying degrees of involvement depending on the proportions of affected versus unaffected X chromosomes. And so the next recommended step for females is mutational analysis of the GLA gene, because often females who are so-called quote-unquote carriers will have relatively normal enzymatic levels but still have the disease. Okay, so for males, you can do the peripheral blood leukocytes. For females, you got to do the genetic sequence analysis. The neuropathy would not typically be associated with membranous. A kidney biopsy would not be the most appropriate step, as there are other less invasive methods. And while the presence of neuropathy and proteinuria could be consistent with diabetes, this doesn't seem to be the case in this otherwise healthy female with no other symptoms. Okay, question 9. With regard to the clinical use of diuretics, which of the following statements is false? Hypoglycemia is a common complication of thiazide diuretics. Bumetanide exhibits less intra- and inter-patient differences in oral bioavailability than furosemide. Hyponatremia is more common with thiazides than loops. Acetazolamide may be useful for treating a diuretic-associated metabolic alkalosis. Eplerenone has greater specificity for the mineralocorticoid receptor and therefore has a weaker association with gynecomastia. So which of those is false? Okay. So most people are going for A, okay, which is the correct answer. Okay. So thiazide diuretics are associated with several electrolyte and metabolic complications, including hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, hyponatremia, and hypokalemia. On the other hand, loops are associated with hypocalcemia, hypokalemia, and hypomagnesemia. And thiazides are more likely to associate with hyponatremia than loop diuretics, as the medullary concentrating gradient remains intact with thiazides, therefore allowing a continually favorable gradient for water to be reabsorbed in the collecting tubule. Question 10, regarding the use of eculizumab, which one of the following statements is true? Eculizumab is most efficacious if given immediately before plasma exchange. Eculizumab is not indicated for the treatment of paroxysmal nocturnal hemoglobinuria. Supplemental dosing is not required for patients receiving fresh frozen plasma. Patients receiving eculizumab should be vaccinated against meningococcus. Or eculizumab is a humanized monoclonal IgG antibody that binds the complement protein C3. So which of those statements is true? Okay, let's check it out. So most people are going for D, which is the correct answer. So eculizumab is a humanized monoclonal IgG that binds to complement protein C5, thereby preventing cleavage to C5a and C5b, ultimately inhibiting formation of the membrane attack complex. It is FDA approved for the treatment of PNH and atypical HUS. Several reports of meningococcal disease have been reported in association, and therefore vaccination is recommended at least 2 weeks prior to use. It is rapidly cleared by plasma exchange and should not be given prior to this treatment. Supplemental dosing is recommended for patients receiving FFP. So question 11. A 70-year-old male was diagnosed with an ST elevation MI requiring deployment of a drug-eluting stent in the LAD artery. His EF was reduced to 15% and he developed severe pulmonary edema requiring treatment with intravenous furosemide. 3 days later, he developed a diffuse maculopapular rash. Which of the following is the next most reasonable step to take? Should we switch IV furosemide to oral furosemide, switch IV furosemide to IV bumetanide, switch IV furosemide to IV chlorothiazide, switch IV furosemide to IV ethacrynic acid, or stop the diuretics and begin extracorporeal ultrafiltration? Okay, so most people are choosing D, switch to ethacrynic acid, which is the correct answer. So when one looks at the chemical structure of furosemide and other related loop diuretics, it contains a sulfa group. The original loop diuretic, here shown on the right-hand side, ethacrynic acid, does not contain a sulfa, and so should not cause problems for patients with sulfa allergies. A thiazide in this clinical setting is unlikely to be efficacious enough, and ultrafiltration is more invasive when other more conservative measures could be considered first for this patient. So question 12, midodrine is increasingly used off-label to reduce the frequency of interdialytic hypotensive events. Which of the following statements is true regarding this medication? Midodrine is highly protein bound. The active metabolite, desglymirodrine, is an alpha-1 agonist, which causes an increase in arteriolar and venous tone. The peak onset of action is within 10 minutes of oral administration. Midodrine is associated with a reflex tachycardia, or the oral bioavailability is poor and it should not be administered with food. Which of those statements is true? Okay, let's check. So a bit of a split here. Most people going for B, some C, D, E, so a wide variety. So the correct answer here is actually B. So the active metabolite is an alpha-1 agonist, which causes an increase in arteriolar and venous tone. So midodrine is rapidly absorbed from the GI tract and is highly bioavailable. The bioavailability of the metabolite is similar with oral and intravenous administration and is not affected by food. It is very poorly protein bound. One of the major side effects is the elevation of systemic pressure, which may associate with a reflex bradycardia as opposed to a reflex tachycardia. And again, the major side effect is supine hypertension, and around 13% of individuals are reported to experience systolic pressures of more than 200. Other side effects include urinary retention, paresthesia, pruritus, and piloerection. So things to watch out for with midodrine. Okay, question 13. 54-year-old African-American woman with end-stage kidney disease secondary to hypertensive nephrosclerosis has developed painful skin lesions on her lower abdomen and upper thigh. Her biopsy was consistent with calcific uremic arteriopathy and she was commenced on sodium thiosulfate therapy. Which of the following statements regarding this treatment is false? So sodium thiosulfate is associated with development of a metabolic alkalosis. It may be associated with excess sodium loading during dialysis. Headache is a common side effect. Sodium thiosulfate is dialysable and should only be given towards the end of dialysis. Sodium thiosulfate can be injected intralesionally to minimize systemic side effects. So which of those statements is false? Okay. So most people choosing E. Next best answer was A. So let's check. So A is actually the incorrect answer. So sodium thiosulfate has several proposed mechanisms in the treatment of calciphylaxis, including complexing with lesional calcium and also antioxidant activity. Accumulation of one of its breakdown products, thiosulfuric acid, can lead to a raised anion gap acidosis, which may necessitate changes in the dialysis prescription. Administration of 25 grams of sodium thiosulfate results in administration of around 7.3 grams of sodium, which over a prolonged treatment phase may associate with greater thirst, interdialytic weight gain, and systolic blood pressure. So metabolic acidosis with sodium thiosulfate is one of the complications. So question 14, regarding autosomal dominant polycystic kidney disease, which of the following statements is false? Defects in the gene PKD1 are responsible for 85 to 90% of clinically detected cases. Polycystin 1 plays an important role in intracellular calcium homeostasis in primary cilia. The PKD1 gene is located on chromosome 4. The frequency of renal stone disease is increased compared with the general population. Or polycystic liver disease is the most common extrarenal manifestation of ADPKD. So which of those statements is false? Okay, let's see. So most people choosing C is incorrect. Okay. So, and that is the right answer. C is incorrect. So autosomal dominant polycystic kidney disease affects between 1 in 100 and 1 in 1,000 individuals. Its PKD1 is located on chromosome 16 and codes for polycystin 1, PKD2 on chromosome 4 and codes for polycystin 2. Both are present in primary cilia and are thought to regulate calcium flux in response to mechanical stimuli. Renal stone disease is estimated to occur in around 20% of patients, therefore much higher than the general population. Hepatic cysts, which are common, increase in frequency with age, so around 20% in the third decade, increasing to around 75% by the seventh decade, with a female predominance. Other extrarenal manifestations include intracranial aneurysms in around 8% of patients, mitral valve prolapse in around 25%, and hypertension, which again is common with progressive chronic kidney disease in around 75% of patients approaching end-stage renal disease. Okay, question 15. Regarding Alport syndrome, which of the following statements is false? It is caused by a defect in the genes coding for alpha-3, alpha-4, or alpha-5 chains of collagen. Ocular manifestations may include an anterior lenticonus. The autosomal dominant form has a faster rate of progression than the X-linked form. Antiglomerular basement membrane antibodies may develop post-transplant, but are typically not directed against the good pasture antigen. Or lamellation of the glomerular basement membrane may be found on electron microscopy evaluation of a renal biopsy. So regarding Alports, which of those statements is false? Okay. So most people choosing C here. And C is the correct answer. So the autosomal dominant form has a faster rate of progression than the X-linked form. That is the correct answer because it's false. So 80% of Alport syndrome is X-linked and are mutations in the COL4A5 gene. 15% autosomal recessive, which is mostly in the COL4A3 or COL4A4 genes. And around 5% are autosomal dominant, again, COL4A3 or COL4A4. The autosomal dominant typically has a slower progression than the X-linked Alports. The co-distribution of collagen, alpha-3, 4, and 5 genes in the cochlea and eye can lead to the presence of hereditary deafness and anterior lenticonus. Electron microscopy shows an irregular diameter of the GBM with splitting and a multilaminated appearance of the lamina densa, which is being called basket weaving. Occurrence of anti-GBM disease occurs in around 5% of those receiving renal transplants, and it's more common in those with an extensive deletion of COL4A5. Okay, question 16. Which of the following statements is false regarding arginine vasopressin? AVP is manufactured in the paraventricular and supraoptic nuclei of the posterior pituitary gland. AVP may have pressor-like effects via binding to the V1A receptors in the vasculature. The stimulus for AVP release is greater for relative volume depletion than for increased plasma osmolality. Cortisol inhibits the secretion of AVP from the paraventricular nuclei. Or copeptin is a cleavage product of AVP that tends to be more biochemically stable. So which of those statements is false? Okay, I'll stop it there. This is my trick question. You ready? Okay, so there's a wide variety of choices here. So the statement that's false actually is A, believe it or not. So AVP is manufactured in the paraventricular and supraoptic nuclei of the posterior pituitary gland. That's false. It is the paraventricular and supraoptic nuclei, but they're in the hypothalamus, not the posterior pituitary gland. Sorry. It is a good one though, right? Okay, so AVP release may be stimulated by stress, pregnancy, hypoglycemia, nicotine, morphine, and may be inhibited by ethanol and phenytoin. And what I forgot to mention one again is the AVP is manufactured in these nuclei in the hypothalamus and transported to the posterior pituitary for release. In terms of the cleavage products, there's the pre-pro FEP is cleaved to vasopressin, neurophysin 2, and copeptin during transport from the hypothalamus to the posterior pituitary. And copeptin is an eminently more stable molecule and is actually becoming more commonplace to measure copeptin levels as opposed to AVP levels in clinical practice. Reminding ourselves of the V1 receptors, so we got V1A responsible for vasoconstriction, 1B for ACTH release, and V2 for antidiuresis. And when you look at the plasma ADH or vasopressin levels in response to changes in plasma osmolality, you can see this relatively linear association, such that as the plasma osmolality increases, the plasma ADH level or vasopressin level increases. Whereas if you have relative volume depletion, rather than a linear pattern, you see almost this exponential curve. So as you go from 5 to 10 to 15% volume depletion, you get this marked rise in plasma ADH levels. And probably the most profound thing to look at here is the units of the y-axis. So here it's from 0 to 12, but here it's 0 to 50. Okay, so your body will preserve blood pressure easily at the expense of osmolality. It doesn't really care what your osmolality is if you can't stand up. Okay. So question 17, 75-year-old African-American male with end-stage renal disease, presumed secondary to type 2 diabetes, has been in dialysis for 2 years. He has a background notable for hypertension, peripheral vascular disease, and gout. His pre-dialysis blood pressure is around 140 to 150 millimeters of mercury. His calculated LDL is 134 mg per deciliter, triglycerides 264 mg per deciliter. And his medications include aspirin, metoprolol, insulin, a multivitamin, warfarin, famotidine, sevelamer hydrochloride, and calcitriol. According to the 2013 KDIGO recommendations, the patient should be prescribed which of the following? Atorvastatin 20 milligrams daily, rosuvastatin 10 milligrams daily, ezetimibe 10 milligrams daily, fenofibrate 160 milligrams daily, or no pharmacological lipid-lowering therapy. Okay, so let's see what you think of this one. So majority of people are saying don't treat, which is, according to these recommendations, the correct answer. Okay, so there were 3 large studies that looked at the treatment of hyperlipidemia in dialysis patients. First one was the 4D study, which was in around 1,200 type 2 diabetics with an elevated baseline LDL compared to atorvastatin 20 versus placebo. A median follow-up of 4 years, and no difference in the primary outcome of cardiovascular death, non-fatal MI, or stroke. There was a marginal reduction in overall cardiac events, but a paradoxical increase in the stroke risk. And in a subgroup analysis, there was a reduction in the primary outcome in those with a baseline LDL above 145, but this was not a pre-specified outcome, not part of the primary outcome, and was not powered for this. It was subgroup analysis. The Aurora study randomized almost 3,000 patients who were not previously on a statin to rosuvastatin 10 milligrams a day versus placebo. Again, this was a relatively long study, median follow-up of 3.8 years, but again, no difference in the primary outcome of the composite of cardiovascular death, non-fatal MI, or stroke. Here again, in a subgroup analysis, there was a potential benefit for patients with diabetes, but again, this was a subgroup analysis, not powered for this as a primary outcome. And again, this higher incidence of hemorrhagic stroke in this study, albeit very small numbers, 12 patients versus 2 patients. Third study to be aware of is the SHARP study, the study of heart and renal protection trial. This was a large study of both CKD and dialysis patients, about 2/3 with CKD and 1/3 on dialysis. Of the dialysis subgroup, which was, again, was 1/3 of the total sample, these patients had no prior history of MI or coronary revascularization. Doesn't mean they didn't have coronary disease, but at least they didn't have an MI or revascularization before participating in this study. And they were randomized to the combination of Simva plus ezetimibe versus placebo, median follow-up of 4.9 years, and again, no significant effect on the incidence of atherosclerotic cardiovascular events. Again, this study, at least the subgroup in dialysis, this was not specifically powered for the dialysis subgroup, and there appeared to be some benefit in the CKD subgroup, but not in the dialysis group. So putting all these together, the KDIGO 2013 guidelines said in adults with dialysis-dependent CKD, we suggest that statins or the statin-ezetimibe combination not be initiated. But here's where it kind of fell down a little bit. So the next line said, in patients already receiving statins or the statin-ezetimibe combo, at the time of initiation, we suggest these agents be continued. So it's kind of a bit of a fudge, right? For hypertriglyceridemia, KDIGO recommends non-pharmacological therapy for fasting trigs above 500 and consideration of drug therapy only for triglycerides more than 1,000. Basically telling you there's no evidence on how to treat hypertriglyceridemia in patients on dialysis. Little or no evidence. So question 18. A 41-year-old woman presents with a 3 to 4 month history of fatigue, dyspnea, and muscle aches. A workup reveals a high serum ACE level, hilar lymphadenopathy, and a lymph node biopsy confirms the diagnosis of sarcoid. Her labs were notable for a serum sodium of 159, creatinine of 0.93, a serum osm of 321. Her urine sodium was 146 millimoles per litre, potassium of around 76, and her urine osm was around 1100 milliosms per kilo. Which is the most likely cause for her hypernatremia? Is this nephrogenic diabetes insipidus due to hypercalcemia, SIADH, central diabetes insipidus, central hypodipsia, or an overdose of sodium chloride tablets? So choose your answer. Okay, so let's stop it there and see. So the correct answer here, well, what did you guys choose? Chose a lot of different things, okay? So let's see what the correct answer is. So the correct answer here is actually central hypodipsia. So the absence of thirst in this history is pretty important here, which suggests a central problem, okay? And so central hypodipsia can be managed by a regular prescription of free water. The high urine osm indicates a maximally concentrated urine, essentially ruling out any form of diabetes insipidus. SIADH, of course, is typically associated with hyponatremia, not hypernatremia. An overdose of sodium chloride tablets could lead to severe hypernatremia, but this didn't seem to be the clinical scenario we were dealing with. And the commonest causes of central hypodipsia are tumors, particularly craniopharyngiomas, anterior communicating artery aneurysms, and sarcoidosis, which was the clinical case here. Never let it be said that I don't give Dr. McMahon the credit that he deserves. He was the person who gave me this question, so thank you. It's recorded for all posterity. So question 19. A 35-year-old man with a history of end-stage renal disease secondary to polycystic kidney disease and a renal transplant 2 years ago presents to the emergency department with diarrhea for 5 days. His medications include tacrolimus, MMF, loperamide, and trimethoprim sulfamethoxazole. On admission, he is euvolemic and normotensive. His emission labs reveal a creatinine of 2 from a baseline of 1.2 and a tacrolimus level of 21. What is the mechanism for the transient increase in tacrolimus levels seen in this patient? Is this poor medication compliance, drug interaction with loperamide, decreased activity of liver CYP3A4, decreased activity of P-glycoprotein in the intestinal mucosa, or decreased gut transit time due to the diarrheal illness? I'm going to stop it there and have a look at what you guys thought. So a bit of a variety here as well. Okay, so the correct answer here is D. So this is decreased activity of P-glycoprotein. So tacrolimus has a relatively low oral bioavailability and approximately 20% reaches the bloodstream, predominantly due to 3 different reasons. One is significant first-pass metabolism in the liver by the cytochrome P450 system. The second one is there's actually local metabolism by CYP3A4 in the intestinal mucosa. And there's also transport out of intestinal cells by this regulated by this protein called P-glycoprotein. So in patients with inflammatory diarrhea, the latter processes are downregulated in the enterocytes, allowing for both increased absorption and decreased gut metabolism of tacrolimus, which results in increased drug levels despite the higher gut transit times related to the diarrheal illness. After resolution of the diarrhea, these mechanisms reconstitute, and of course, drug levels return to normal. So we got one final question. So a 29-year-old woman with a history of polysubstance abuse and epilepsy presents in status epilepticus. Phenytoin and propofol at 5 mg per kilo per hour were commenced. She was intubated and ventilated. On hospital day 4, her labs were as follows. She had a CPK of 100,000, BUN of 22, a creatinine of 1.8. Other notable labs include a K of 5.4, bicarb of 8 millimoles per litre, a lactate of 8, and a blood pH of 7.2. Her blood pressure was 130 on 60, heart rate 85, she was afebrile, and her ECG, she developed a new right bundle branch block. What is the most likely diagnosis? Is this seizure-induced rhabdo, propofol infusion syndrome, septic shock, neuroleptic malignant syndrome, or phenytoin-induced rhabdomyolysis? Okay, so let's have a look. So most people here are choosing propofol infusion syndrome, which is the correct answer. So propofol at high doses more than 4 mg per kilo per hour and for long periods more than 24 to 48 hours can inhibit the mitochondrial electron transport chain, leading to impaired oxygen utilization and the buildup of toxic fatty acid metabolites. You will require 3 things for the diagnosis: 3 of lactic acidosis, rhabdomyolysis, cardiac dysfunction, acute kidney injury, and hyperlipidemia within 3 days. The overall incidence is quite rare, less than 1%, but the mortality is up to 30%. And risk factors include prolonged use at high doses, exogenous catecholamine use, corticosteroids, and poor carbohydrate intake. The treatment involves obviously stopping the propofol, and prolonged dialysis or CVVH may be necessary to clear the drug as it is generally poorly cleared by dialysis. So I've left you with some suggested reading. Wish you all a good night. Enjoy the room service, and we'll see you bright and early in the morning.